Hello, I'm Richard Stark. I'm a neurologist at the Alfred Hospital in Melbourne. We're hoping this video will help GPs in their management of migraine. Headaches must be one of the most common reasons that patients come to see a clinician for treatment. There's always concern about diagnosis, but the great majority of patients have a primary headache disorder, and in fact most of those are migraine. The best way to diagnose migraine is to go through the clinical features of the headache that are associated with it. So we look for nausea, light sensitivity, sound sensitivity, and in particular whether the headache is sufficient to be disabling or to limit day-to-day activities. The ID migraine protocol enables one to diagnose migraine with a 3-question technique. If 2 of the 3 questions are yes, the diagnosis is probably migraine. When we're assessing a patient who may have migraine, apart from making the diagnosis and checking for the features that make the diagnosis, it's important to look at other aspects of the patient's condition, particularly the things that will affect treatment options. How frequent the migraine is, how disabling it is, what treatment might be required at different times. The thing is, we have 3 treatment options or 3 treatment strategies. One can deal with triggers, and patients will tell us which triggers are likely to trigger their migraine. In most cases, patients will have dealt with that already. If migraines are provoked by a certain food, they avoid it. The second strategy is to treat migraines with appropriate medications when the headache occurs. There are a number of options: triptans, anti-inflammatories and painkillers. One of the important things to look at is whether the migraines are frequent enough to require preventive strategies, and there are a number of strategies that are available. We've tended to rely predominantly on pharmacological preventive medications, and many of these are effective, and there are a number of choices. However, all of them have got their own set of side effects, and there are a number of patients for whom individual medications are not appropriate. For example, a patient who's struggling with overweight will not want to take pizotifen. A patient who has asthma will not want to take a beta blocker. And there are some patients that just have a natural antipathy to taking tablets every day. We're often asked, therefore, whether there are strategies that might be available to patients for prevention of migraine that don't involve drugs. And there are a number of strategies. There are lifestyle strategies, and it's recognised that patients who exercise regularly are likely to have fewer headaches, so that they can be advised about lifestyle strategies in that way. These days, we're fortunate in having a number of other strategies to deal with headaches at a preventive level, and one of those strategies relates to electrical stimulation techniques. Some patients find that treatment with acupuncture is helpful for treating headaches. It's a little controversial because it's not clear that acupuncture in the standard sites is any better than sham sites or random sites, but nevertheless some patients find it helpful. Many patients will have headaches that seem to be triggered by stressful situations, and it makes sense to try to reduce the level of stress in patients' lives. Some patients find psychological approaches helpful in dealing with their headaches as well. And again, there is some controversy about the best way of intervening in this way. Most patients respond well to simple strategies dealing with triggers, acute treatment and preventive medication, but there are some patients who don't respond so well, and these are the patients that probably should be referred for specialist care. Another reason for referral would be anxiety about the diagnosis. There are a number of red flags that raise the question of a different diagnosis, things like a new pattern of headache, increasing frequency of headache, increasing severity of headache. headache associated with neurological symptoms that are not typical of ordinary migraine aura, or headaches associated with such things as fever or indications of general systemic disorder. These are the sorts of things that should raise the possibility of investigation and referral for neurological care. What I'd like to emphasise is that migraine is probably underdiagnosed and I think is often not adequately treated. We do have effective treatments for migraine, both acute treatments and preventive strategies, and the preventive strategies these days include not only standard pharmacological agents but other non-pharmacological methods.